Hello, and welcome to the virtual breakout session. Hello, camera. There we go. I'm Ross Camidge from University of Colorado, and my colleagues here are.
Dr. Carl Gay from MD Anderson Cancer Center in Houston, Texas.
And
Dr. Shirish Gadgeel, medical oncologist from Henry Ford in Detroit, Michigan.
so we are the three amigos, and the questions you can send through the chat function, and then we'll select which ones we're interested in or which are most prominent, and then we'll take it from there. So the first question I've got popping up on our feed here is, for Dr. Camidge, what change in tumor markers prompt a PET? That's a great question. If you can take a PET scan every 3 to 4 months, there's no point in doing additional tumor markers, which is what you asked. In terms of if you're just getting CT scans, what's the change? Nobody really knows. It's a trend. It's not a single value, but I would say kind of 3 points sort of increasing each time might make me suspicious. Shirish, I don't think you actually use the tumor markers, so.
No, I don't, though I'm intrigued by the way you presented the case earlier today, and I might start doing it. I have been starting to do only in the last 1 year ctDNA, so I would get it at a baseline, and then at 3 to 6 months, I'm repeating it. I don't know that it has necessarily made a difference in the few patients that I've done it as of now. But the question is really going to be, if it is showing an increasing trend, would I make any changes? But I've not faced that sort of a clinical situation as yet.
And then why do you check the ctDNA?
The hope is that can we assess, this is particularly in patients who have a response, but there is still a fair amount of tumor evident on the scans. And my thought process has been that if I see a persistent level, particularly a rising level of ctDNA, do I consider adding chemotherapy in those patients? Again, this is not every patient. These are patients who have, to begin with, high volume disease. And if I start on ALK TKI and I don't see sufficient response, and in that situation see a rising ctDNA. So it's a very, very specific situation. As I mentioned, I've not yet done that because I've not faced that situation as yet, but that's my thought process. I am not looking to, when I was routinely starting alectinib, I was not considering switching to lorlatinib in the event the ctDNA went up without radiologic evidence of progression. I was really looking to see, should I be adding a different sort of cancer therapy to get a better tumor control than what I was getting with the ALK TKI alone.
Carl, let's ask you. So at MD Anderson, or at least in your practice, do you do any blood-based monitoring?
So I will say we do not routinely do tumor markers. It may vary from practitioner to practitioner, but I'm not aware of anybody that's routinely doing that. Although, as Shirish said, I think your presentation intrigues me at using that as an adjunct to some of the surveillance monitoring that we do. ctDNA, I think, is something that we are just starting to incorporate into some of our targeted therapy patients, both for initial clearance of ctDNA, as well as for sort of an assistance in monitoring early progression, whether it's to intensify therapy, as suggested there, with the addition of chemo, or potentially to switch therapy, probably more of the former than the latter for most folks.
Yeah. We've got some nice questions here about, because of course the real world doesn't sort of obey any of these rules. What happens if you have a CT contrast allergy? How do you tweak your surveillance?
Yeah, I mean, I will say in all of my patients, I tend to get at least one PET per year. That may just be sort of superstitious of me, but I'll do like Q3 to 4 month imaging for virtually all my patients are doing well, but I will do one PET a year. If I have a patient that has a contrast allergy, I will probably shift to doing predominantly PETs. A CT without contrast, there's just so many things that you can miss on that. I would not want that to be my sole form of surveillance, I think.
Yeah, I would say a CT, unless you just have disease in your lungs, when you can actually get away with a CT without contrast. If you have anything in soft tissue, lymph nodes, liver, anywhere else, a CT without contrast, I would say, is next to useless. How much do you pre-medicate? Do you push them through? Do you get them through the contrast allergy?
Yeah, I've done it. I definitely are people who get a steroid Benadryl prep 12 hours and 6 hours before, and then post contrast as well. But yeah, I agree with Carl. Most of those patients have switched to a PET scan instead of continuing with the CT.
I'm going to keep on the surveillance questions. There's a question here about the frequency of brain MRIs, and somebody's getting one every year. Should it be every 6 months? What do you do?
I've been getting it about 6 to 9 months. I'm just going to mention one case, and doesn't really necessarily go with the surveillance. Interestingly, I had a patient who had lung-only disease for almost 12 years. The patient was on crizotinib and then subsequently alectinib. And now 12 years after a diagnosis, on a surveillance MRI, we detected a solitary brain met. I mean, I started thinking that this patient is never going to develop a brain met, and I was questioning what is the value of doing surveillance scans. Now, clearly, this is one case anecdote, and I'm not saying that justifies brain surveillance, but I was quite surprised that this patient developed 12 years later. A patient who not only didn't have brain mets, but patiently had bilateral lung disease. That was her only site of disease. So,
Wow. Yeah, I mean, I still do MRI surveillance. I think for somebody who has brain metastases, I obviously scan them more frequently. If they don't, I'd say it's somewhere between 6 months and 12 months for me. But Carl, what do you do?
Yeah, so for my patients that have no history of prior brain metastases, I will generally still do one MRI annually. I've often toyed with this notion of is there some point where I would stop doing this MRI? Certainly the anecdote here makes me think perhaps I should not. It only takes 1 or 2 cases like that, I think, for you to think that the risk of an annual MRI is not so great, right? Yeah. And so I will probably continue in perpetuity, for any of my patients who are on therapy.
I think one of the earliest down patients has had over 100 MRIs in her lifetime, and she had this thing called gadolinium staining, which is, so gadolinium is the dye you use for an MRI, and it was just sort of there in her brain even when she wasn't getting it. But we don't know it has any significance. It's, like a tattoo in your brain. It's like, who cares? So I think, as we move people hopefully into decades of maintenance control, maybe we're going to have to tweak how we do some of these studies, but at the moment I'd say the downsides of an MRI are pretty small. Guys, if you see a question that you get excited to, then grab it. I've got one question here that says, if your tumor markers are going up and you have clean scans, what else could it be? Well, obviously it depends on what you mean by clean scans. I would be doing a PET scan, I would be doing an MRI with contrast, and then if nothing shows up on that, you're kind of waiting for the other shoe to drop. So I do think that tumor markers can be more sensitive than the ctDNA. The question is, if an alarm bell goes off and says there's going to be a fire sometime in the next 5 years, is that very useful? So sometimes they can be hypersensitive. Do you want to grab a question?
Adverse effect.
Did you see one?
Yeah, there's a question up there that's one that I know we banter about in the clinic sometimes, which is a question about Zometa for patients who have a history of bone metastases who are started initially on a bisphosphonate, but then have essentially a complete response to therapy. For how long should they continue Zometa? And we definitely have practitioners that do both extremes of that. I tend to fall into to one category where if a patient has had a complete response in their bones and their bone lesions have sclerose, I stop Zometa, and I don't think it's probably doing anything. But I have some other folks that continue it indefinitely. Once bone mets, always bone mets. And so I don't think there's certainly for ALK specifically strong data either way, but I don't see the purpose in continuing it indefinitely for patients that have had a complete response.
Yeah, I would agree. When you stop it, do you have a certain number of cycles that you want to give before you stop it?
No, I guess I've not followed any particular trend with that. I'm waiting until all of the lesions are metabolically inactive on PET and are sclerosed on the CT portion of the PET, and I use that as my threshold. And that often happens very quickly, within 3 to 6 months.
So I actually wait to start, particularly zoledronic acid, because I have seen some patients after the first infusion develop sort of side effects. And so what I like to do is start the patient on TKI, maybe even for a couple of months, not add the Zometa, unless there's a very critical, significant lytic bone metastases. And I do it every 3 months. I don't do it every 3 weeks, right from get-go. And then I actually do stop it, assuming the disease is reasonably controlled after, say, 1.5, 2 years. It's important to remember that zoledronic acid data was in an era where we only were using chemotherapy. That was almost 20 years ago, and it showed, improvement in bone fractures, bone pain. But I don't think there's any data in the era of targeted therapy or immunotherapy. And I'm not suggesting that this should not be done. I mean, it does have value, but I don't know that it has the value. And by the way, even in the original studies, it was done only for 2 years, particularly in breast cancer and prostate cancer. To some extent, that may be because the patients lived only, didn't live long enough, and so that's why they probably stopped it. I'm not certain. But I don't know that that there's any data in the era of targeted therapy and immunotherapy, and secondly, we really don't know what the right duration of treatment is, particularly in ALK patients who can go on for years together. Finally, there are patients who are on drugs for osteoporosis just because they have underlying osteoporosis. And if they are taking that, I'm perfectly comfortable stopping the Zometa or not even starting the Zometa and having them continue that.
So there's three of us here, so of course I have a different opinion.
Okay.
If you walk through the door and I know you have a targetable oncogene and I'm going to put you on a targeted therapy, let's say ALK, this is an ALK positive format, I actually don't even start the Zometa or the Xgeva. I actually think you get sufficient healing without the TKI. We actually have a study looking at bone turnover without it, and I suspect it will show very similar. If they develop bone deposits later, maybe I'll add it in. If somebody comes to me for a second opinion and transitions care, and they've already started on it, then I'll kind of finish off a course. And again, it's just a line in the sand, like 6 doses I'll do, and then I'll stop. Did you get? Oh, it's your turn.
No, I like the question of the de-escalation. So,
Do you want to read the question?
yeah, what are your thoughts on the de-escalation study? Now, I don't know that there's a specific de-escalation study. I suspect, are you open to that with your patients? So I don't know the specifics of the study, but I was very fascinated that at the Crown presentation, somebody from the audience asked the question as to would you consider stopping lorlatinib in any of the patients. Now, I personally would not consider stopping the drug in any patient, but I just was amazed that at a lung cancer session at ASCO, even that question was entertained by somebody, and I thought that was fascinating. It is, to me, quite interesting that CML is one disease where targeted therapy has resulted in almost normal life expectancy. It may be just a coincidence, both CML and ALK positive lung cancer are translocations. And I'm not trying to compare ALK with CML, and genomically CML might be a lot more cleaner disease in that it doesn't have too many other mutations impacting the outcome. And so if you target the main genetic alteration, you get normal life expectancy. But I definitely wonder whether there is an ability to some patients to be able to stop treatment truly if with long-term follow-up. And that's an intriguing thought. Another aspect of de-escalation is there are these mathematical models. Researchers at Moffitt, I'm certain at other centers also, are looking at sort of the survival theory, something that Dr. Camidge earlier today talked about. And the question is, if you, instead of, I don't know if that is necessarily de-escalation, but kind of having monitoring with sort of ctDNA, and could the ctDNA go down to a certain level where you could interrupt the treatment so as to kind of look at the different clones and allow the clones that are sort of sensitive to actually grow back a little bit to control the clone of cells that are not controlled with the initial TKI. And by sort of giving this intermittent treatment, you may actually control the tumor better. This is hypothesis. This has not been tested, and the biggest drawback of this strategy is that we don't have good sensitive tools to measure at a molecular level whether the tumor is under good control or not. Sorry, I went on much longer than I expected. I found the whole de-escalation strategy quite interesting.
Well, the de-escalation gets us to lead into Dr. Gay's, one of his areas of specialization. So in the early stage setting, where somebody might be having neo-adjuvant, so before definitive therapy, or adjuvant after surgery or radiation, how long would you keep that TKI going?
Yeah, this is a really valuable question, and we even incorporate surgery and radiation consolidation into a lot of our patients that have stage 4, but sort of low volume disease early on, and this question comes up there. So far I think we follow the data, right? For if you have a patient that's following the Alina protocol, you'd sort of follow the duration there. But if you have a patient that had very early stage disease, somehow you got them, say alectinib in the neoadjuvant setting, took them to surgery, they had a complete pathologic response at the time of surgery. It's hard to argue that patient then needs lifelong TKI after that. But all of the time points feel very arbitrary, right? I think that we've seen this dichotomy come up in the EGFR scenario, right, with LAURA and AD-AURA, where now they're trying to push it further, right? Indefinite TKI after chemoradiation. I think particularly given the age of a lot of these patients, that seems crazy, but at the same time, it's hard to just come up with a number, right? And say 6 months or 12 months is enough because, as was said, we just don't have the MRD tests that we need to declare that. And so I would not commit someone to lifelong therapy, but then I don't have any evidence to back up other than what's published any stopping point before that.
Yeah, so I had a remote second opinion the other day with somebody who had gone on adjuvant alectinib, so they'd had surgery, then adjuvant for 2 years. Everyone told them it was all good, safe, and then 18 months later they progressed. And there are similar, so although the adjuvant studies with EGFR inhibitors are still relatively early in their follow-up, there were, I think, Japanese studies which have had longer follow-up which show that the people who had an adjuvant EGFR inhibitor, when you stop it, they relapse. So I still don't believe it's a cure. The problem is when you're committing people to lifelong therapy, some of them may have been cured by the surgery, and so you've got this, like, it all depends on how much the cost is, how much your side effects are, and your comfort with saying, okay, maybe I don't need this, maybe I do. Here's one. Would you recommend increasing doses of alectinib from 6 pills to 8 pills today? So that's from, I can't do that in my head, 450 to 600 twice a day. Even if no progression or side effects after 4.5 years? I'd say no. Does anyone disagree?
Consensus.
It's like if it's not broken.
Broke,
yeah, exactly.
4 years is a long time. Though it's interesting, the question above is of liver enzymes, and the patient was on the standard dose of 600 milligram twice daily, and then subsequently developed liver enzyme elevation and went down on the dose to 300 twice daily, and then 450 twice daily. Looks like patient has a response, though has a persistent lesion. I am sort of, I might try going up again to 600. I've had some patients where you give them a short break, start at a lower dose, and then when you go back up, the liver enzymes have not gone back up again. So that's something to try. But I think if you stay at 450 twice daily and your scans are stable, I have no problem staying. I don't know that I would necessarily switch to lorlatinib at this point. Now, this is where I have sort of had a little bit of a difference based on the brain mets. So if a patient does have brain mets, I'm much more inclined to switch the patient to lorlatinib in this situation.
Yeah, I was getting ready to prompt you with the same thing to ask, what if they had brain mets, or would you change your surveillance for brain mets if they were on sort of a dose level -1, say? Because I probably would. I might scan this patient's brain twice a year instead of once a year if they were on a lower dose, just because that might be the first place you lose control.
So I'm going to give a counter argument to that, just because that's the fun of it.
Yeah.
So one of the things is it's not about the dose. It's about the exposure that your body gets.
Yeah.
So I could take all three of us, give us the same dose, but the levels we get in our blood may be different.
Very good point.
And that might be reflected in whether I get side effects or not.
Absolutely. The only thing I will say is that the question is, absolutely take toxicity as drug dose level.
Okay.
My only concern is we do feel that in general the levels in the CNS are a bit lower
Yeah.
than the systemic exposure. And so in a patient with brain mets, I think 450 might be achieving sufficient systemic exposure in that patient based on the liver enzyme elevation. I don't know if I have certainty that it is. So if somebody didn't have brain mets, I would say, okay, fine, continue. Somebody did have brain mets. I don't know. I might be, now, again, there could be nuance to that also, right? If it's a 3 millimeter lesion that responded very well, I might just continue. But if I had multiple brain lesions, I might be inclined to switch to lorlatinib. But it definitely would be. The more interesting thing was, if there's truly a 1.5 centimeter lesion left, more than switching would be the local consolidation
let's
therapy.
consolidate that.
Yeah, so
that'll be a little worrying, but
yeah.
There's a few simple ones we'll pick off. Have you had patients with Mets to ovaries? Yes, they're called Krukenberg tumors. It's just a site where stuff in the abdomen likes to stick to. As long as it's the same cancer, they'll still respond. Occasionally, they're a great site for actually resection.
That's right. Yeah.
What have we got? Which ctDNA test do you use, Dr. Gadgeel?
So I usually use Guardant, if that's the Guardant 360.
Okay, let's try and. Someone keeps saying, why Nuvalent not mentioned? It's like we're not trying to hide it. So I mentioned it in my talk, and the thing about Nuvalent is Nuvalent 655 is a so-called fourth generation ALK inhibitor. We've got relatively limited clinical data available on it. It clearly works. It clearly works better if you have a proven ALK mutation as your mechanism of resistance, and certainly I've seen many people go into that study who have a second driver who don't respond. Do you guys, within the limits of what we can talk about public data, do you have any comments on Nuvalent?
The public data and my own anecdotal experience matches exactly what you just said. Right? I've had positive experiences with it in my own clinic panel in patients that had progressed on lorlatinib, an N of 2, right, but had on-target resistance to lorlatinib, and so clearly there's real activity there, but it is not a panacea, right? It is for a niche of the resistance that happens.
I mean, what's the goal of Nuvalent is essentially it has two things it's trying to do. It's trying to be a better tolerated lorlatinib, so they've dialed out this thing called NTRK, which is something that lorlatinib hits that may be responsible for some of the side effects, and Nuvalent doesn't hit that, so it may be at least not have those side effects, although it may have its other ones. Secondly, will it be as good? You know, you don't want to compromise the efficacy of lorlatinib, so will it be as good at getting into the brain? It certainly works on most of the resistance mutations, including some additional ones preclinically, but again, that's not the problem in some patients. What have we got there?
Not every patient, do all lorlatinib patients take statins? Most lorlatinib patients have cholesterol elevation, but that doesn't necessarily translate into everybody taking statins. There continues to be a minority of patients who can manage the cholesterol elevation with dietary intervention, but yeah. Cholesterol elevation is very common, and a
So
good
it's like
proportion of that.
80%, 80?
The rise in cholesterol, yeah, probably it's very high. I don't remember the exact percentage, but it is high.
What have we got? LCT is local consolidation therapy.
Yes.
Is quote unquote, I asked my oncologist about the LCT and he said not at this point. Should I seek a second opinion? Well, that depends on why they said no. So that could be because your response is too good, there's nothing to see. It could be because your disease is still in the areas where it's hard to define the borders. Maybe there's fluid, something else. So it depends on why there was a no said, or you're just too early in the process. So again, let's come back to Dr. Gay and his area of specialization. One of his areas of specialization is these kind of local multidisciplinary approaches to people. So who do you or do you not do it in the stage 4 setting?
Yeah, I mean, it's certainly not a one-size-fits-all approach, although I think we're in the early days of understanding who it's best for and who it's not. I think you hit on some of those things. You know, you can have a very small lesion, but it might be pleural, and that is much less amenable to local consolidation than something that's well circumscribed in the lung parenchyma. I think a few things that have emerged from our institutional experience with early local consolidation in patients with metastatic disease is patients that have lower volumes of disease, patients that have fewer overall metastases, as well as patients that clear their ctDNA early on, seem to have sort of gain a bit more benefit from local consolidation, and especially if you can consolidate the entirety of their disease. And so that's sort of the framework that we work within when we're working with our radiation oncologists and our thoracic surgeon colleagues. But I would say it's more of a gestalt approach than a than a
you
hard
know
and
it when
fast
you
rule.
see it.
Exactly.
Yeah,
Yeah.
it's not very helpful to you out there. But so one question is, do you only consolidate radiation to still PET avid lesions? Well, let's say you had those bone mets and now they've shut off on the PET scan. Do you still irradiate them because there was cancer there?
I would say typically not. So a relatively common scenario for us is a patient whose only sites of quote-unquote distant metastatic disease were bone lesions that sclerose, and then they have a primary lung tumor, maybe nodal disease. Those patients will often, at our institution, go and see thoracic surgery, and if they're a candidate, have surgery, but they will not have the residual, whatever residual disease might be in the bones, consolidated at that point. If there's any hint of any activity there or any lack of sclerosis, though, we will go ahead and err on the side of caution.
Yeah, and I don't think any of us know the right thing to do.
Absolutely
I have to
not.
tell you that, given I don't believe that lesion is cured, there'll still be residual persistent cells. We irradiate anything that we can still identify as where cancer was. Shirish, are you doing it or not?
I'm doing it very selectively. One of the things that I see a lot of patients who have a lot of volume of disease, liver mets, multiple bone mets, multiple brain mets, and patients have a very good response. But if you still see a fair amount of disease, whether it's PET avid or not, but you're still seeing a fair amount of disease despite significant shrinkage, I don't know what the value of that is. So I look at the baseline volume of disease as a guide to decide whether to do local consolidation therapy.
And on that note, we're going to have to wrap it up. That's why it's getting noisier here. We're going to move on to the next panel of doctors. Thanks for listening.
Thank you. Thank you.